for educational and quality improvement purposes. And if you have specific concerns regarding this, please reach out to Diane in the chat privately. By participating in the call, by participating in the call, I thought I closed everything out. You are consenting on this recording. So slides from today's call, as I had mentioned, along with the video recording that we will have of the lecture only, will be shared following the meeting. This is to ensure confidentiality and also to provide a safe place to discuss the concerns and ask any questions. And again, we just do have another quick friendly reminder that we please ask to ensure that patient privacy is protected and that we do not provide any PHI during today's call or any of our echo sessions. So we actually now will move into our key presentation for our lecture, which is with our very own Zep Fuller. Our presentation today is on the key criteria to consider in implementing an infection control program in a healthcare setting during a global pandemic. Zep has more than 13 years experience working with a variety of healthcare delivery systems. She holds a Master's of Science degree in Healthcare Administration with a concentration in education. Zep is also a certified professional in healthcare quality, and she's a committed servant leader for the Indigenous communities and helps organizations build capacity to provide quality care. So with that, I will now hand it over to Ms. Zepporah Fuller.
Thank you, Mel. Everybody. My name is Zepporah Fuller. I am Navajo. I am currently located in Phoenix, Arizona, and I'm definitely happy to be here just listening to everybody's projects and what you're all working on. So I'm hoping that today will definitely be a good day to take away some beneficial knowledge that you guys can apply to your organizations and really increase the quality of your patient care and also ensure the safety of your patients and your staff. Next slide, please. I have no relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this activity, and I do not intend to discuss an unapproved investigative use of a commercial product or device in our presentation. Next slide, please. So today's objectives, as you've noticed prior to this particular presentation, Mel was able to go over the introduction to the ECHO program. And for this section, more so specifically, participants will develop an understanding of key components around the implementation of an infection control program. And we're going to be using the CPHQ accreditation manual version 41 for those of you guys that are newer to the CPHQ world and those that might not be an ambulatory center. It's a really good manual to just incorporate into your organizational library, just so that you have it. It's very robust. It's very straightforward, easy to understand. Extra resource, again, that your organization can utilize, and also found any quality improvement committee work that your organizations are working on as well. And then there are some OSHA and CDC, I should say some OSHA resources, but also a lot of CDC resources and tips and suggestions and I want to say effective procedures have also been incorporated as well. Next slide, please. So we wanted to start this out with just discussing what the key criteria of implementing and maintaining an IPC program would look like, essentially, if you're developing one or if you already have one in place. And so you'll notice here, I'll briefly read from some of the bullets, but I really like to expound on how these can be applied within your particular organization and how they're applicable to UIOs. So for the first component, having an organization or a program that's geared toward preventing and controlling infections and communicable diseases is key. I know that many states also incorporate a state communicable diseases report as well. And so that should also be incorporated into your program. So I wanted to just talk about for the next bullet point, what it looks like to develop and maintain a program to ensure environments are clean and safe. And this is really just a robust, comprehensive list of programs that I've worked with in the past with UIOs in particular. Having a safety program is essential. Having a QI and QA program is also very, very, very important. Including a risk management program or team, if you will, committee, also including an emergency preparedness program, are all essential to ensuring that you do have a robust IPC program. One thing that I wanted to add to this bullet point is staff training. That is also one that often is sometimes an Achilles heel. I know that for my prior organization, I'm trying to track down, who's had annual, training was one of our areas of opportunity. And the CPHC, HRSA, the Joint Commission, CARF, and OUIHP through IHS, the Office of Urban Indian Health Programs, all have a timeline set in place for specific training. So having a timeline as to when you'd like things to be completed is crucial. So staff training, again, around safety, in this instance, bloodborne pathogens trainings, sharps injury training, safe injection practices training. The CPHC just incorporated a newer infection prevention and control training as well, and that's the tuberculosis detection and prevention plan that they're now going to be asking for. So just ensuring that you have an exposure plan in place, especially with COVID-19. So what do you do if your staff member is exposed? Do you have a negative pressure room in your facility? What does that look like? How are you guys isolating those patients who are waiting for an appointment from those that are already in the rooms? Really ensuring that there's a good, substantial workflow and processes in place for that. Also staying up to date on current trends. We often know that there's an influx of newsletters that you guys get, I'm sure, in your emails, but signing up for the main accreditory and I want to say regulatory bodies is really important. HRSA, again, the CPHC, the Joint Commission, CARF, and NCQA all have really amazing newsletters that include trainings, resources, and white papers that you guys can also apply and take back to your organizations. I found that sometimes when you incorporate hospital workflows and effective hospital strategies, conducive to keeping a safe environment often works for UIOs, even though we're not as big as a hospital would be, but it's definitely a great idea to try and implement those existing effective strategies into your, I want to say, rotation, if you will. Also making sure that you stay on top of your CLIA requirements. If you do have a lab in place, just ensuring that you're up to date on those CLIA requirements, especially if you're renewing your CLIA licensures as well. I would also suggest, again, just remaining flexible in this approach. You'll notice bullet 4 talks about adapting your program to the current needs. And so for this, one of the great resources that the CPHC has is they have worksheets at the back of their manual. You'll notice there is a clinical records worksheet. They're able to be tailored for you to make your own checklist for a monthly walkthrough, if you will. I know at my previous organization, we did a monthly surveillance report. It was a focused IPC report. So of course we checked to see if any of the sharps containers were full. We checked to see and ensure that any of the hazardous waste was accurately labeled. So we really, again, wanted to make sure that the IPC program includes all elements. And as I go into the next couple of slides, you'll notice that there are more elements that are going to be listed. So next slide, please. For this section here, for the designation of a qualified healthcare professional with training, we definitely used one of our volunteer nurses in a consultant capacity, which also might help out for folks who have volunteers that are maybe itching to get in there, that are retirees, retired physicians as well. So it's also another possibility, because often when you have a compliance or QA officer in their position, they're often wearing multiple hats. So that's just one suggestion as well of how to use some of your support staff. Developing and augmenting a written program for infection prevention control. This includes that sharps injury prevention. The reason why the sharps injury prevention is separated out is because the CPHC, again, has a tailored requirement for that, just to ensure that organizations are tracking how many sharps injuries that are occurring. This also lends to the inclusion of what a robust IPC program plan would look like. And that includes just ensuring that you have an education and training section within your plan. How are you guys training your staff? What does that look like? The surveillance reporting. What does your incident reporting system look like? Are staff appropriately being trained to report that? Is there good accountability within your organization to say, hey, I stuck myself with a needle, or hey, I fell on, these stairs or what have you, but just making sure that there is that accountability for incident reporting. Standard precautions is also a part of the IPC plan that you should have. So your plan should really include what it looks like, what we mean by hand hygiene, using PPE, donning and doffing, medication storage and handling, your cleaning and disinfection procedures, your SHRP's injury prevention, any disposal of biological waste, and any supporting policies and procedures should also be included in your plan. Again, for my prior organization, I believe we had 30 supporting policies and procedures that were in the appendix of our plan. And it was, again, very, very robust inclusion of resources that we're able to tap into that supported our IPC plan. Some additional forms that we'd added to our plan included having the state lab incident reporting form, just for quick, easy access for staff. And I believe it was actually digital at the time. So we included that link in there. Again, that communicable disease reporting form is also listed to help prevent any outbreaks. I know that there was one year where we had a strep outbreak. So it was interesting in our county, we had a high influx of that just circling the city for, I want to say about a month and a half or so, but it was just interesting how it had occurred. Again, suggest that you create your own tailored IPC monthly surveillance form, as well as conducting a monthly risk assessment. That's another key component that also helped us to maintain high scores on our CPHQ site visits. But again, it was a lot of work, but it was a lot of work that we made into a day-to-day surveillance for our team members to really ensure, again, that we weren't waiting 3 to like 6 months to try and fix something. The other thing about the portion for the reporting is having your board members sign off on it, and their signature does need to be somewhere on the IPC plans for the AAHC. So just something to also keep in mind. Next slide, please. And for this continued slide, for the cross-contamination and cross-infection, some key procedures that we'd added that were policies listed as references in our IPC plan was including who the designated personnel was to ensure that the cleaning was occurring, making sure that all of our team members were trained on what that looked like, and maybe even rotating the responsibility as well. We also made sure that that bloodborne pathogens policy included how we selected our cleaning products, ensuring that they are EPA registered, FDA approved. We also included who would be maintaining our inventory of cleaning products, ensuring that there was no shortfall and ensuring that we did have an adequate amount of cleaning products. We also listed the frequency of our cleaning, and we did follow the terminal cleaning workflow for this particular element, if you will, when cleaning between patients. In addition to that, having a blood and bodily substances policy, a cleaning of blood and bodily substances policy was also very helpful in this regard. And also adding in the bathrooms and housekeeping cleaning policies were also very beneficial for our overall cross-contamination and blood pathogen policy. Here, the last bullet point, which speaks to following the guidelines of the manufacturers, that is key. The AAHC will definitely ask you all to ensure that you're following the manufacturer's guidelines. The Achilles heel that we had here was with reference to any recalls. That is also a big key. A big takeaway is to ensure you have somebody who is designated to receive any and all recalls that your organization is receiving. And that is applicable to any medication recalls and equipment recalls, and also medical device recalls as well. We had one instance for an organization that I'd worked with. Their finance person was receiving the medical equipment recalls, and then the quality officer was receiving the medical device, and then I believe the CMO was receiving medication. And one of their employees had left, and so they could not figure out where the recalls went. There was one, I think it was a piece of furniture in the patient waiting room that was recalled because the stand on it would break unintentionally, and you didn't even have to be sitting on it. And so we were wondering what was going on with our chairs, and so we finally decided to Google it, and the recall popped up, and that's when we were like, uh-oh, we have a place of opportunity here to do better. So just an example of how important a recall could be for your organizations, and just, again, making sure that you have somebody designated to receive those. Next slide, please. Adhering to your safety program. Again, this is another really important element when it comes to having a robust IPC program. When we think of safety, there's often different ways that we can think about it. We think about environmental safety. We think about violence in the workplace safety. We think about ensuring that there is no cross-contamination happening. And so your safety program should really adhere to all of these and also be very comprehensive. A good safety plan, again, would include designating who the key personnel are and what their role in that plan is. Speaking to environmental hazards, and that includes any sort of natural disasters. Most recently, we had one of our UIOs who had to deal with a forest fire in California. And so it was really trying to figure out, has the organization updated their emergency response plan for that? More recently here in Phoenix as well, sometimes our AC would go out and we'd be in the middle of a heat wave. So just really thinking about those elements again in terms of environmental hazards. Again, thinking through in your safety plan what your incident reporting system looks like. What does that workflow look like? Who receives those? How do you respond? How are you training staff? And that's also one of the annual mandatory trainings that the CPHC, HRSA, and OUIHP also has in place. So just keeping that in mind. What do your medical recalls look like? Your vaccine storage and your medication storage. What are some of your backup plans in the event your refrigerator goes out? You have a generator in place. Again, really thinking about the sharps injury prevention, thinking about your sterilization practices and your chemical exposure protocols. That would also be a part of your safety plan. Some of this for bullet point 2, when you're training your staff in the basic life support, that also includes things like your first aid, CPR, and more recently, the mental health first aid certification has also been one of the elements that's newer to the, I want to say, FQHC world. I'm really requesting that folks are mental health certified to address any sort of situations where there might be a staff member or even a patient coming to you. I don't know if you guys have ever had a patient come in, who is really depressed. Our organization in my last UIO was near one of the higher homeless sections of town. And so we often would have homeless folks come in, and some of them would just be having mental health breakdowns in the middle of our lobby. So really training our frontline staff to take a look at what that looks like in order to keep our patients and our staff safe as well. The training program that we included was, again, on a rotation. So we had a list of trainings that we needed. And as these ones pertain to safety, we had the, again, emergency preparedness. What does it look like if you were to have an active shooter come in? What does it look like if we were to have a heat wave? We had staff trained in fire extinguisher use, as well as performing fire drills. In addition to that, we also did have a code blue training and did annual code drills, assessments and trainings for the organization. And that's a big CPHC must have, or must complete, I should say. So those are just a couple of the trainings in addition to the basic life support that are mandatory. The next section goes into the recall of drugs, devices, and equipment. And I do appreciate that they kept them separate because I highly recommend keeping all 3 of these in a place where we do have somebody monitoring them at all times. Next slide. This one here again speaks to what I'd already briefly touched on for the date of expiration. What does it look like if your medications have expired? We had a policy in place, which was our medication dispensing and storage policy. And that included things such as who would be ordering our drugs, where it would be stored, how would we dispense it, what the administration look like if it was maybe an injection or if it was just like a standard aspirin What did the inventory look like? If we had to store vaccines again, what does that refrigeration, monitoring, logging, temperature checks, and controls look like? Looking at expired medications monthly and understanding that how our team would dispose of it. Also looking at our containers, making sure there were none that were broken, none that were maybe placed near like a Sharps injury if folks were taken out. Maybe a tissue, if you will. That was another thing that we learned, is to make sure that your tissue boxes aren't like near a storage waste container. Also ensuring that you separate your cleaning products from your medications. So you don't want to store like your Clorox near any of the medication bins. Again, just making sure that you also have a policy that states that. And then also ensuring that if there is a vaccine storage, that you guys do have a vaccine log that does record that as well. Next slide, please. And the next slide, again, talks to the, I want to say the medical equipment, drug documentation as it pertains to cleaning, transport, reprocessing, inspection, or repair. Again, all of these have different elements. I think the biggest area of concern for medical equipment or medical devices was any recalls, that were detrimental to the patient and staff. They were either using it or maybe the equipment was being used on. So really paying attention to what that looks like. For the CPHC, you should know that for the individual.
Hi, Zep, it seems like you lost audio. I know that Zep had some internet fluctuations earlier this morning, and I think we may have lost her. So I can wrap up this slide, and then we can move into any questions or answers, and then onto our case. So for this slide, we want to develop written policies on documenting the management of medical device as it relates to pre-cleaning, transport, reprocessing, inspection, or repair. Follow the guidelines from the manufacturer's single-use devices. This must comply with FDA regulation, and the device must be approved for reprocessing as it relates to FDA 510(k) clearance. We want to document instructions provided to patients when medical devices are distributed, and this is so that they can refer back to the instructions as they use their device. We also want to provide education to intended operators of new device equipment before use and document appropriately. Some patients are sometimes accompanied by others who will assist them in the use of their devices, so we want to provide this training before they leave the appointment. Next slide.
We have Zep back.
Zep, there you are. I wrapped up the prior slide for you. I figured your internet was fluctuating. I know for the echo session, yeah, we have like 14 minutes left for the echo session. So I'll let you finish this up and then we'll move into the case.
Yeah, no, thank you so much. Sorry about that all. But yeah, everything is, it generally ties into each other, and I'm sure the CDC IPC team can hand you a good document, because the CPHC does have the standards as to where you can find what written policies are needed and how you can tie in all of these extra elements. And I am also available to help you guys comb through your policies to make sure it is appropriate to what the CPHC is looking for, as well as HRSA. And if you're Joint Commission accredited, we also do have staff who have experience with that as well. Aside from that, if we go to the next slide, that definitely wraps up our infection prevention and control component and elements. The biggest key takeaway from here is I would also encourage you to have a multidisciplinary team in place, which would include your CMO or your medical director, your quality improvement person. It could be a manager, your compliance officer, your safety facilities maintenance guy, your head nurse, also your finance. You want to keep your budget folks also in the know, especially if you have a equipment malfunction or equipment failure. They're going to need to know what happened and also ask for the incident report on that too. The other element is also including housekeeping. I can't remember which regulatory agency it was, but we had a housekeeping agency that was contracted with us, and we actually had to provide them the HHC mandatory training as well, because they needed to have that documented. So just a couple of things to think about as you begin to develop your infection prevention control program planning, or even updating. And I'm going to go ahead and stop there. Thank you all.